everyone, welcome to our webinar today. I'm just going to give it a few more seconds so people can come in from the waiting room, and then we're going to get started. Okay, so thank you again for coming to today's webinar on the very important topic of does medication work in the treatment of eating disorders? Or I think, to be more accurate, my question is, why doesn't medication work in the treatment of eating disorders? And I know a lot of parents feel the same way. So I'd like to welcome Dr. Perlman, who is joining us today as our webinar presenter. I just want to go through a few rules before we start. So please note that you need to be muted and you need your camera off through the entire webinar. We would like you to utilize the chat box to ask questions. I'm going to put in a specific request, which is that you only ask questions through the chat box and only questions which are particularly relevant to this topic. And please don't ask about your personal situation. There's no way that Dr. Perlman can answer you in the 30 seconds per answer that she has about your child's particular case. So I'm going to ask you not to ask specific questions, keep it very general, keep it relevant, and please don't put comments in the chat box. Because what happens is when I go to curate the questions, it's really, really hard for me. When there's a lot of comments, sometimes I miss the questions. So now that we've finished with that, we can move on to our webinar. So thank you all very much for joining us today. And I'd like to introduce Dr. Perlman, and you can get started now.
Wonderful. Thank you all for joining. Bear with me. I'm going to pull up my slides now. All right. Go. Okay. So thank you all. As let me put it in slideshow mode. All right. If there's any problems hearing me or seeing my screen, just again, as Judy said, please make notes in the chat box. I'm really honored to be here to speak with you all today about medications and the treatment of eating disorders. And as Judy said, or the other question is, why don't they work? I will go through, a little bit of an overview of how I, as a psychiatrist working in eating disorders, thinks about the individual in the context of the eating disorder as well as other mental health symptoms, and then move on to some overview of the medications. We're not going to get into a lot of detail on individual medications. I'm sure there's questions on that, but I wanted to give this as a first step overview. I'll just share with you a little bit of my bio. I am the Chief Medical Officer at Montanito and Affiliates, which is an eating disorder treatment provider around the United States. I'm board certified in psychiatry as well as addiction medicine. I've been treating exclusively eating disorder clients for well over a decade. And I supervise all of our psychiatrists and psychiatric nurse practitioners throughout the country. So I have a lot of experience. I love working with individual clients. I'm a parent myself, with someone who's been through the mental health system as well. So I understand what it's like as a parent going through this and just wanting some answers and guidance. So I list there some of the committees I'm involved in. One that I'm very proud of is the Eating Disorder Coalition, which is a national advocacy organization in the U.S. So if you're interested and live in the United States, I encourage you to use your voice to advocate for more dollars, federal dollars for research, so that we can get to a place where we might have more options for treatments for our loved ones. So this is a brief outline. First, I don't need to teach you all about what eating disorders are, but just going to level set on a slide about that. Really talk about what's going on in the brain as a premise to help us understand what medications may or may not be able to do for a brain that's with an eating disorder, and then talk about the other co-occurring mental illnesses like depression and anxiety, because those can really be treated sometimes with the medications. And that's where you'll see our clients being prescribed medications, maybe not necessarily for the eating disorder, but for the other symptoms that might be driving or worsening the eating disorder. And then talk about, what we think about when we're approaching medications with someone with an eating disorder, and like I said, in a psychiatric disorder like depression, and then go over some tips for loved ones. We know that eating disorders are life-threatening. These are psychiatric disorders, but they also have a lot of physical and medical consequences. There's involving emotions, strong emotions, attitudes, and behaviors surrounding weight, food, size, but we know it's not just that. There's a range of causes. There's not just one cause. There's some genetic component, but obviously the environment plays a big role. And I could give a whole talk on social media, but we are seeing the effects of social media increasing the incidence of eating disorders. So that is a significant factor we're facing. And then there's like I said, serious effects on the health, and functionality. You all know people with eating disorders are incredibly sharp and brilliant and high achievers often, but yet the eating disorder just clouds judgment and gets in the way of relationships and ability to really function in the way that they can and want to. And then we know early intervention increases likelihood of full recovery. And that's where, when I'm working with a family I will suggest medication if it's indicated, because if we can get to this problem and use all the tools in the toolbox, food first, therapy right alongside, but then if we have a medication that might move things along faster, that's really our goal. Early intervention, the sooner we can tackle this and get someone in remission, the better. And so that's where a medication can be one more tool. So again, understanding the context of this when we as psychiatrists are thinking about eating disorder treatment, these are brain diseases. Psychiatrists are physicians. We go through medical school, and really we're trained to focus on the brain and understand the neurotransmitter system, the chemicals in the brain that might be off balance in the throes of a mental illness. And that's where not just medication can reshape and get those neurotransmitters back on track, but so can therapy and behavior change. So quite frankly, just learning to eat, on a set meal plan is a change, and that change in behavior, actually studies have shown, can then change that imbalance. So again, not the answer is not, here's a pill that will solve it. If we knew we had that, then how wonderful that we wouldn't have so many dealing with these terrible diseases. Like I said, we know genetics can be a factor, but a lot of times it's the environment that creates that can turn on or turn off these genes. So again, someone who might be in an activity where maybe body is a focus of the activity, like dance or wrestling, there can be an environment, a setup to then trigger an eating disorder. What we find and what psychiatrists know is that we need to treat the whole person. If we focus on the eating disorder alone, yet someone has severe OCD, which is obsessive compulsive disorder, or severe anxiety, that we need to also address that at the same time. If we only look at things as one disease process, we're not going to be able to best support the individual. Eating disorders start often in adolescence, although I can tell you I work across the age spectrum and I see individuals dealing with this for decades. And again, it's the reason why we really want to address this early and sometimes aggressively if they're not responding initially to first line treatments like FBT. We might need to think about another tool, which would be a medication. Obviously, as I mentioned, we've got these stress and cultural pressures that we're seeing heightened with social media, and then in the context of the pandemic, things really took off, particularly for our young individuals who are inundated with these images, and not just images, but harmful content that's being pushed to them, amplified through social media, and that can affect the brain. So let me dig in. Now, these next 4 slides are probably the most technical. I don't, many of you are coming in as veterans with this disease and could probably tell me more about this than I could, but I do want to just share what's happening in the eating disorder brain. And, first and foremost, we know that some kids just come out a certain way. Some are anxious, some are, fearless. And we know that there's a certain temperament and personality that eating disorders are, in some ways drawn to. That someone who's more of that anxious perfectionist person, harm avoidant, so not going to be the first person to raise their arm in class to take a stab at an answer and get it wrong. Want to sit back, watch, observe, won't be the first one to jump on the field to play a game. They want to watch, make sure they get it right, jump in, when they feel they'll be the best at it. And so there's these achievement oriented folks, fantastic. Like this is, they, many of them, if an eating disorder, thank goodness, isn't a part of their life, go on to great achievements. And this is where the eating disorder can latch on, and the eating disorder brain can get very good at the eating disorder, as we know. Some of the other features that we see is cognitive inflexibility, being rule bound, which I think is great. And quite frankly, when we have clients who are very focused and beholden to rules, it makes things easier for treatment. You have to eat 3 meals and 3 snacks today. This is the plan, and so they're driven to want to fall in line. However, we know that loud eating disorder voice can just be so challenging. So we're looking at this, and then what can sometimes trigger in this type of temperament would be sometimes a setting of a depression onset, maybe a breakup, maybe a trauma experience that, but again, sometimes there doesn't need to be a trigger. We also see, along with this sort of rigidity, there are sometimes this emotional dysregulation. I can say sometimes we all have kids. We know that it's sometimes more than sometimes, but this up and down, this, really just jumping in, lack of persistence, really impulsive behavior, and then rejecting and saying, this, that I don't want to be around that person, or, really this kind of impulsivity then can lead to even more eating disorder behaviors, particularly binging and purging, but also restricting. It's a maladaptive way to manage. So this, I think, is really helpful. And these studies have been repeated multiple times, but I apologize, it's a little fuzzy, but I hope you can get the takeaway image here. So there's a normal brain on the left side, and you can see the brain is filling the whole space of the skull. Now it's a side profile, so on the left end you can see the nose, and the top is the brain, and it's full. Now on the right is a picture of a brain with anorexia nervosa. There's little red arrows pointing to black space. That is where there's been gray matter loss. The brain shrinks in the throes of an eating disorder. Now, the good news is, and it's not just anorexia, this has been repeated with bulimia as well as atypical anorexia. It's not about the number on the scale, but about the weight loss, the malnutrition. The brain is shrinking. It doesn't have the nutrients it needs. Brain is largely made up of fats. So the fat cells are, when someone's malnourished, the first thing the body does is to use up those fat cells to get energy. And we can see that this happens even in the brain. Like I said, the good news, this is reversible, completely reversible with recovery from the eating disorder. And the treatment is food. I'm going to say this over and over. Food is the number one medicine. You know, this is going to nourish not just the brain, all the organ systems. It gets people back on track with a routine. The meal time is so important. So, you know, again, I wish there was a magic pill, and the closest thing to it is food, nourishment. So, you know, again, not to scare individuals, but this is when you think about how hard it must be in the throes of an eating disorder to just sort out the cognition, the thought process, the emotions, managing all that with less reserve in the brain. I will say, it's not the same condition, but a brain like this on the right, with the gray matter loss is what a brain looks like with dementia, with something like Alzheimer's, where they're just, you can think about a dementia where it's planning, cognition, thinking through things, judgment, insight are all impaired. Good news, it gets completely better. Again, this is probably the most technical slide, but I put these words in here because if you are interested more in this, you can Google some of these keywords to learn more. But what we know is there's a picture at the bottom, this red area deep inside the brain. And this is not just the only area affected by eating disorders, but this is a really important center of the brain that manages our interpretation of the environment. We all need this working to really be fully functioning. And what we know in the eating disorders, this area called the insula does have disrupted signaling. And so what it is supposed to do is manage what's called interoceptive awareness. And when that's altered, the eating disorder brain can have sometimes decreased hunger sensation. That's problematic. The brain's not telling them that they're hungry. Distorted body image, again, what they're seeing in the outside world is being misinterpreted. So if they look in a mirror, the brain is saying something different than what's the actual reality. Lack of recognition of malnutrition, and we know this is one of the hallmarks of anorexia nervosa, and it's striking and strong. I've taken care of many physicians who know very well that the body cannot function in this malnourished state, yet for they themselves, they don't see it as a problem. And that is a disruption in the insula. Numbing of emotions. There's a thing called alexithymia. That's a description of a emotional state of really just disconnected, blah, numb. You know, I ask a client in the throes of an eating disorder, how are you? And they might not even know, or they just say okay because they think that's what they're supposed to say. It's some real blunting. And so we want to get them back to themselves. And guess what the medicine is? It's food. So the good news is all of this is repairable when someone's recovered from an eating disorder. I'll note that there's a lot of things going on with the appetite that we all are subject to, and particularly the eating disorder brain. When someone's depressed or anxious, it affects appetite. That's one of the hallmark signs of depression is weight loss or weight gain. In primary care offices, providers are trained over and over. If you see fluctuations in weight, ask about mood. Well, we'd like them to also ask about eating disorders, but that's another story. We're getting there. Medication can certainly affect appetite, and I'll talk about some of the side effects of these medications that we use because we don't want to necessarily, or sometimes we need these medications. So if they're affecting the appetite, we need to be aware of that. We don't want to, if we can avoid it, give a medication that suppresses the appetite. And some medications like stimulants for ADHD, like Ritalin or Adderall, these are amphetamine-based medications, so crucial for ADHD, but sometimes they suppress the appetite so much that we have to hold them. Natural chemical signaling hunger and fullness cues are altered in the eating disorder. So when someone is, for example, binge eating, this is not about willpower or lack of willpower. The body is not sensing when it's full or telling that there's chemicals that as the stomach stretches, sends a message to the brain, okay, we're getting full, you know, time to put down the fork. those are not working when someone's in the throes of an eating disorder, so much, especially in the binge eating disorder or bulimia. Now, appetite signals return to normal once they're recovered. Again, good news. This is the hard part too for many of us. For those with healthy eating habits, healthy relationship with food, we're able to enjoy, a delicious meal. A delicious meal put in front of someone with an eating disorder, that brain signaling might be interpreted as anxiety, not pleasure. So we have to be mindful of that. That's a concerning thing for them to have to overcome. And a lot of that is just practice and exposure until those brain signals are returned to baseline. And then there's this altered reward process. So it may affect why we see low motivation for recovery and low mood. There isn't that pleasure feedback, which is dopamine, which is a chemical in our brain. So what do we do with this neurobiology? Using this information, we can support our loved ones in recovery. Now, if they can't necessarily rely on these internal cues, these brain chemicals working properly in the throes of an eating disorder, what do we need to rely on? We rely on predictable external structure. That means a meal plan. That means, getting up and going to bed the same time every day, having a routine. Structure is helpful, as we all know, for all of us, but certainly in the throes of an eating disorder when the brain is just trying to sort out and interpret cues that maybe they're misinterpreting. Relying on advanced planning, again, with the meals and snacks, knowing what's coming ahead, increasing this predictability, the routines and boundaries. Loving boundaries are some of the hardest things for us to do as parents, but also the most necessary. And that really makes things a lot more manageable when we're trying to move someone through recovery of the eating disorder. And then practice, mindfulness, really looking at encouraging our loved ones to connect with what their mind and body are signaling to each other. That literally helps rebuild those signals in the brain. Okay, so I have to mention the co-occurring mental illnesses like depression and anxiety, because these are the disorders that we're typically treating with medication. And the couple slides here, and then we'll get to medication. So on the left, you'll see what do we see? Now, this is in our studies. I have the privilege of overseeing our research studies in my group, and we have over 6,000 patients enrolled. So we're able to follow them throughout treatment and long term. And what I've been able to see is that those who need higher levels of care, who are in residential level care, which is 24/7 level or inpatient, the vast majority have depression or another mood disorder, which would be considered bipolar disorder. Much smaller percent, 7% of those had bipolar. The rest had major depression. We're also seeing a lot of anxiety disorders, social anxiety, a lot of anxiety with all the eating disorders, but particularly ARFID, which is, as many of you know, an eating disorder where it's not so much about body image, but more around restrictive behavior, fear of choking, disinterest in certain textures of food, and food variety can actually cause anxiety. So we often are treating anxiety in clients with ARFID and, quite frankly, all the eating disorders. What we know also is post-traumatic stress disorder. In our studies, you can see on the right, almost half of the adults and 35% of the adolescents meet full criteria for post-traumatic stress disorder. So that's beyond trauma. That's developing a disorder where there's a lot of symptoms around nightmares, avoidance of any triggers, avoidance of relationships. So that can be very impairing. And what we found is we've got to treat that or any of the other underlying disorders, including things like attention deficit hyperactive disorder I mentioned, substance use. Personality disorders can sometimes go hand in hand with eating disorders, but I really educate providers out there. We're not going to be giving a diagnosis when someone's in the throes of an eating disorder and a label for personality disorder, because when in recovery, the ups and downs and mood swings certainly are different. Self-harm and suicidal thoughts, unfortunately, are very common among our population. So, again, that might be going hand in hand with a mood disorder that we must treat the depression, and medications often are first line for that. Now, I'm going to skip through some of this, but data, hopefully, a little bit of hope. If anyone's dealing in the midst of an eating disorder, treatment does work, and this is some of the data I've been publishing on with my team, that those who go through treatment do very well on not just the eating disorder, but the depression, the anxiety, the PTSD if it's present, and they maintain it 6 months later. So structured treatment works, whether it's FBT, outpatient if your team recommends it, higher levels of care, IOP, PHP. But the good news is treatment works with or without medications. Not all those clients were on medications. We take it case by case. So let's jump in and really get in the nuts and bolts here on the medication. Now, I've mentioned this, that as you know, eating disorders are complex. There's a lot going on with the brain and the neurotransmitters. In the middle slide, or the middle here under the neurotransmitter dysregulation, big words, but it means that we've got some of these signals that you probably heard of: serotonin, dopamine, norepinephrine. These are chemicals that, when they're not firing properly, we can see symptoms, including depression, anxiety, and eating disorders. The medications target these imbalances. So while there's no magic pill to target exactly the eating disorder, we do have medications that can target the imbalance of these. I will say that, when a family or a client's asking me about medication options, I often say, while you're in treatment, this is a time to give it a shot, because you're going to have access, often, to a psychiatrist or a psychiatric nurse practitioner, or a provider of some kind who knows these psychiatric medications for the mental illness and the eating disorder. So that while you're with a team, that's a really good time. You can ask questions. The therapist can then explain what they know about the medication, or connect you with the nurses or the psychiatrist. So there's some myths and realities I first wanted to point out. The first truth is that psychiatric medications are meant to correct this imbalance that we know are happening with the neurotransmitter system. Like I said, with the serotonin and the dopamine, for example, not meant to change someone's personality. So I do try to reassure clients and families, if you do feel like your personality has changed, that you're now numb or no longer feeling your emotions, tell your provider, because that's not what we're aiming for. But what it instead is doing is correcting the underlying conditions that might be keeping the anxiety very high. And what we want to do is bring it to a manageable state, not so low that now there's no anxiety, no feeling, it's only numbing, and you feel like you're, blah. That's not what we want. So you've got to really talk to your provider. It's to improve symptoms and functionality. Truth number two: if you stop taking a medication, you don't relapse back into the disorder due to withdrawal. I do educate people, like, it's your choice to take a medication. We provide the facts and our clinical expertise. What we know will help, what we see will help, what are the side effects. And then we partner together, really encourage clients of all ages to talk to loved ones too, so that they can help understand and notice if there's any side effects. But if they stop the medication, yes, maybe if the medication was for depression and it was helping keep the depression at bay, there's a chance the depression could relapse, because we know that the majority of depressions are relapsing. And then, someone might choose to then go back on the antidepressant. But it does not mean that you're necessarily need to be on it for life. That being said, some clients choose to stay on it long term, because they do find such relief. And then the third truth I wanted to share is, once we start, particularly an antidepressant medication, and the next slide, I think I'll go into what those are. Those are things you might have heard some of the names, like fluoxetine, which is Prozac, sertraline, which is Zoloft. Those medications take a while to work, 4 to 8 weeks. So it's frustrating for all of us for someone to not be able to get instant relief from these meds, but they do work in at least 2/3 of individuals once they're on a good dose and they've been on it for several weeks. So I encourage people that to really make it work and have good efficacy, I'd recommend they stay on it for about a year and then reassess. That does not mean they have to stay on it for a year. Obviously, their provider will say, hey, if you're having side effects, we're gonna um, lower the dose or switch it or stop it altogether. But all right, let's talk about our 3 big bucket disorders and what medication we could use. Anorexia nervosa, unfortunately, does not have any FDA, that's the Food and Drug Administration approved medication. There's no single medication that we could prescribe to treat anorexia, but what we are treating when we're often using medications that I've listed here that you may have heard of, like olanzapine or aripiprazole, there's some data behind these and some published studies that these actually help with ruminating thoughts and distortions. So I'm going to get into what that means in the next slide. So again, treating a symptom of the eating disorder, but it's not a pill to make the disorder go away. Now, the good news is there is one approved and studied medication for bulimia, fluoxetine, which is Prozac, at high doses, 60 to 80 milligrams. So 60 milligrams is considered a full dose. The study looked at 60 to 80 milligrams. So the providers, if the patient is on this medication and they're not getting well, the provider might need to increase the dose. But what it's been shown to do is reduce binging and purging. Again, you know, this is one medication. We're going to be treating the whole person. So if, for example, they're on a different antidepressant and it's helping, because fluoxetine is also approved for depression, if they're already on something like sertraline, which is also called Zoloft, and that's managing their depression well, we're not going to stop it and switch to Prozac if they have bulimia, because what is understood in further studies is that most of these antidepressants, which are broadly called SSRIs, that means serotonin, selective serotonin reuptake inhibitors, these often work for bulimia. Now, again, it doesn't mean that the person will be able to stop engaging in the eating disorder behaviors alone without a structured meal plan and a dietitian and family support, but it is a great tool in the toolbox. So, binge eating disorder. We do have one medication approved for binge eating disorder, lisdexamfetamine, which is a stimulant. The brand name is Vyvanse. It's approved for moderate to severe binge eating disorder. We use it cautiously because it does have side effects. Primarily, it can increase blood pressure. So if someone does have any cardiac heart problems, we're probably not going to be ordering this medication. Again, similar to the medicine we have for bulimia. This is used in tandem with a dietitian, with a therapist, with family support. The disorder is complex. There is not just a single pill. So I did say I wanted to talk about ruminating thoughts for a minute. Rumination is one of several forms of repetitive thinking. And if you think about what your loved one experiences, this probably makes a lot of sense. It's a mode of responding to distress that involves repetitively, passively focusing on symptoms of distress, on the possible causes and consequences of these symptoms. What I see, especially in young people, you know, the overthinking, oh my gosh, I can't believe I said that to that person, or I can't believe I said that in group. They must think I'm an idiot. And then going through this spiral of overthinking. It can be all consuming, especially when there's an eating disorder present. I can't believe I ate that yesterday. I'm going to need to run this amount to burn up the calories, the nonstop thinking. Research suggests that ruminations are a particularly detrimental form of repetitive thinking. And we found predict anxiety, binge eating, binge drinking, self-injury, depression. I will point out that in the United States, the American Psychiatric Association had historically set out guidelines for high levels of care. So residential, meaning they need 24/7 level of care. And one of the criteria would be to have intrusive or ruminating thoughts for 4 to 6 hours a day. Well, our clients are probably burdened by these thoughts all waking moments of the day, and they will tell me this. They cannot turn these thoughts off, and this is where some medication can sometimes help. What I tell clients, again, we're using these off-label; these are not approved for eating disorders, but things like olanzapine that some of you have heard about, which is also called Zyprexa. That one's the most published on and most used. I do like that one. Aripiprazole is another one, and lorazepam, another one, where they, as well as others in this class of medications, are really give that space. They don't take away the eating disorder. They don't take away the ruminating eating disorder thoughts. It gives the client space. And I explain it to the client that it gives them that moment to pause and get out of the spin and be able to think about something else. Oh, my friend just told a joke and now I'm aware and I can think about that for a minute. What relief, even for a moment. So I do really like these medications. There are side effects. Again, we use very small doses. These are not approved. We use typically, for example, olanzapine, maybe 2.5 milligrams. It can go up to 30 milligrams, but we're using very small doses. These medications can be sedating, so we are giving them often at night. And there can be an association with weight gain. So we do need to be honest and monitor the client on that. Our stance is that we really want to help people get nourished with food. If there's alteration in the weight that's excessive, I did have a client gain 8 pounds a week for several weeks due to olanzapine. I had to stop it. This is a side effect of this medication that's not helpful. You've got to stick with your meal plan because that will throw off their recovery if they're on a medication like that. Now, especially for adolescents or young people where we're not getting any traction and they're continuing to be malnourished, low weight, it can be a helpful tool, again, to get the recovery, the weight gain going. But primarily recommend using it for these ruminations, which go hand in hand with the fear of eating and weight gain. Okay. The next 2 slides, I have listed the medication names and the buckets of where you see us using them. Like I said, we don't necessarily have medications other than the one for bulimia, which is fluoxetine, and the one for binge eating disorder, Vyvanse. There are no other medications even approved for eating disorders, but there are many medications approved for the other issues our clients are facing. Anxiety disorders, sleep disorders, depression, major depression, or other mood disorders like bipolar, which I'll talk about in the next slide. So what medications are we using first for anxiety, which, as we know, can go hand in hand with the eating disorder? Valerian root, it's natural, over the counter. I like to use it sometimes for especially adolescents. It does not mean that just because it's over the counter or considered a supplement that it has no side effects. Please tell your providers, your doctors, if your loved one is taking a medication that's over the counter, a supplement, because they can interact with some other medications and make them not work as well, or even actually make them stronger. So doses might need to be adjusted. Hydroxyzine. Now, you might have heard of this one. We use it quite commonly. The brand names include Vistaril and Atarax. It's an antihistamine. That means it can be used, antihistamines are used to for like a runny nose to dry you up. But what we know in this case, hydroxyzine is actually well studied for anxiety, that it helps relieve the anxiety. And it's really nice because it's not habit forming. you'll see the list at the bottom, the benzodiazepines. That's a class of medications that are approved for anxiety, work very well, very quickly. For example, as you might have heard of Ativan, which is lorazepam, Klonopin, also called clonazepam, Xanax, also called alprazolam. You take it, your anxiety's lifted, you feel better, but it doesn't treat the underlying anxiety. And that's where we use the ones listed right above, the antidepressants. Buspirone, also classified, approved for anxiety, works very similar to what's classified as SSRIs. These are medications you take daily, scheduled. You don't skip the dose because it builds up in the system. And these are the ones I mentioned. Ideally, whether they're prescribed for anxiety or depression, they work best over the course of a year. So you've got to hang in there and give it 4 to 8 weeks to really see the benefits. One more on this list that I see here, propranolol. It's an old blood pressure medicine, but it mostly affects the tachycardia, the heart racing that we can see with anxiety, the physical symptoms. And some clients feel really much better when they're able to take this medication. It reduces the physical signs of anxiety. You've got to watch out though. Many of our clients have low blood pressure, so they might not be able to take that. Insomnia, sleep hygiene is number one. Google sleep hygiene. We want to help our loved ones get back on track with their sleep, ideally without pills. Really, sleep is so key and so important. We want that adults to have 8 hours of sleep. Adolescents need more. Child and adolescents, 12 hours. Their body is growing. No screen time before bed. That light on the phone is stimulating, as well as the content. No caffeine. No exercise before bed, all of the standard things you would think of. It needs to be a dark, quiet room, no TV in bed. Sleep hygiene is key. But if we need a boost to help someone initiate sleep, there are some medications that you'll see psychiatrists consider. Melatonin, again, a supplement over the counter, but talk to your doctors, especially for young clients, young people. It is a hormone. Our body, our brain makes our own melatonin. So it really shouldn't be used long-term, daily over the course of months or more, because then our body will stop making as much of our natural melatonin. So caution. I like it. It's a helpful, going on a plane ride. It's very, safe, but again, not to be used long-term. Trazodone is an old antidepressant that we found just put people to sleep. And at smaller doses, we use it just as a sleep aid. And what's nice about trazodone, that it not just initiates sleep, but it helps maintain the sleep. So psychiatrists, we're going to ask about sleep quality, and you want to start your loved one, when they're reporting their sleep problems, should think about, do they have trouble falling asleep or staying asleep, or both? Because we're going to be able to pick different medications depending. Prazosin. This is a helpful medication for nightmares. Now, if someone has post-traumatic stress disorder where they've experienced a trauma and developed PTSD, nightmares are common, and prazosin or prazosin has been shown to reduce the frequency of nightmares. I find it extremely helpful. It's not habit forming. The problem with it, though, it's an old blood pressure medicine, and it can drop the blood pressure. So we have to use small doses, but it can be very helpful with nightmares. And then I've listed some other ones. Mirtazapine is an old antidepressant that also leads to sedation. So I like it. You can use it for both of those things. Now, depression, I've listed a lot of the drug names there. I'm not going to go into them one by one. They're considered broken down into a couple of classes. SSRIs, you'll see most of these names you might be familiar with. They work similarly, and they're approved for depression, and most also have approval for anxiety disorders, and some additionally have approval for obsessive compulsive disorder. So your loved one might have a few different symptoms or disorders that they're managing along with their eating disorder, and might be prescribed one medication, maybe fluoxetine, that can address all of those symptoms, and because it's approved for all OCD, anxiety disorders, and depression. SNRIs, similar to SSRIs, I find these very helpful for clients, especially if they've already tried the ones above it, the SSRIs, and they haven't had good success. And then the other ones listed at the bottom, you'll see that are used, aripiprazole and olanzapine that we use for the ruminating thoughts are also approved as add-on to an antidepressant for depression, as well as some other ones in that class. So you'll see these used for a variety of reasons. And what really, to step away, what we're treating as a psychiatrist is the whole person, understanding the disorders, what their brain is dealing with in the moment. I do want to point out there's one called bupropion. The brand name is Wellbutrin. We don't use that in eating disorders, in bulimia or anorexia when someone's malnourished, because it can increase the risk of seizures. Now, if someone's on it, I'm going to have a conversation and really work to transition them to something else. It also doesn't help with anxiety, and most of our clients have anxiety. So you get a lot more benefit if you're switched to SSRI or SNRI and what we see. I'm going to skip through this one. These are lesser, as I mentioned, bipolar is less common in eating disorders, but there are some good, what we call mood stabilizers, that you'll see these clients on to help deal with the mood swings. I find lamotrigine, which is Lamictal, probably the most helpful in our population because it's mostly weight neutral, and clients feel that it does help their mood. Post-traumatic stress disorder, as I mentioned, some of the antidepressants are approved for that, and the prazosin for nightmares, as well as therapy. And then the ADHD can go hand in hand. If a client can't focus to sit down at the meal because they have attention deficit disorder, they're going to probably eventually going to need to be considered for medication. Now, they don't all have to start with a stimulant, which, as I mentioned, can lower the appetite. Instead, we might choose something like Strattera, which is or guanfacine, clonidine. These are medications approved for ADHD that don't affect the appetite. Now, one other little nugget to think about, and then I have just a couple wrap-up slides. Now, we might have poor response to antidepressant medications when someone's malnourished. So look at this picture here. Tryptophan comes from food. Tryptophan is the precursor for serotonin. Serotonin is that really important chemical in the brain that affects our anxiety, depression, eating disorder symptoms. So if there's not enough tryptophan being consumed through a variety of foods, and you'll see the list there on the right, the client is not going to have enough serotonin built up in their brain. And then when we give a medication like an SSRI, such as fluoxetine, that's targeting serotonin, it's not going to work very well. There's just not enough serotonin being made and stored in the brain without enough tryptophan. So think about that. It does not mean that we stop the antidepressant. If it's helping some people, we take it case by case. But again, food is our medicine. And I really try to encourage clients, this is, we've got to nourish the brain. We've got to nourish the brain. The medication will work better once the brain is nourished. I do want to say a word, cannabis, which is marijuana. This is a whole separate lecture I give nationally, but I am very concerned about the increased use of cannabis, vaping the cannabis oil. What we do know is that it worsens mental health problems. People with mental illnesses, including eating disorders, anxiety, or depression, should not use cannabis. It numbs emotions. It's worsening the avoidance of their relationships, which is one of the key goals of getting back into life, is connection with others. Cannabis in use in adolescence is associated with a decrease in IQ. And it has been shown in many big studies to increase self-harm, increase suicidal thoughts, worsen anxiety long term. Now, the client might say in the moment they feel relief when they're high, but long term, it's actually worsening the anxiety disorder. So, again, a message there. Now, there have been medical uses for someone with chemotherapy related nausea, things like that. There are some medical reasons why someone might be on it, but if they have an eating disorder, it's not going to help. It could worsen things. And then just my last couple wrap up slides, and Judy will open it up for questions, but just some do's and don'ts, keeping in mind, being honest and vocal, and remind, with your loved ones is the best way to go. Suggest, that they seek professional help, being a good role model. It's hard. We're all on our phones, and then we can tell, the young people in our lives, you put too much time into your phone, get off the phone, and it's hard for us to do the same. So we have to be mindful of the modeling, but don't place blame on yourself. This is not something that any of us caused. This is a brain disease that can be treated. Again, food is the number one medicine. Making rules and promises we can't uphold, but rules are super helpful, but we've got to reinforce and enforce them. And then, supporting someone when they're in treatment and towards recovery. Again, body acceptance and body neutrality is key. Avoiding any talk about changes in their bodies, and instead encouraging, our bodies are really helpful to help us live our fullest lives. So encouraging them to find parts of their body that they can accept now. And then practically, if their body is changing, just, order on Amazon some, size medium, size large sweatpants, whatever they need to just feel comfortable in their body as it changes. Don't get attached to the numbers on the clothing or the scale, obviously. And then supporting loved ones in treatment and recovery. It's hard, but making sure you're taking care of yourselves, again, modeling ample amounts of movement, rest, fun, and food. Stop walking on eggshells. I know it's easier said than done, but when someone's in treatment, that's the best time to really step back and let the team manage the mood dysregulation, and let yourself step back and help manage those firm boundaries. Again, at the bottom, discouraging harmful social media content. Harder said than done, but there are ways, especially if your loved one is underage, where parents can put in controls to block certain harmful content. And then social connections, we know, not just through the screen, but social in-person connections are going to be key. I mentioned eatingdisordercoalition.org is a way to take action if you want to use your voice to advocate through simply texts, alerts, things like that, or coming to DC with us in May to advocate. And I'll wrap up there. There's a QR code if you want to read some of the studies that I've been working on that I mentioned, and I'll end there. Thank you so much for your time and attention.
Wow, thank you. You covered so much ground. There are a lot of amazing questions. We're going to get to as many as we can. We're just going to do a speed round here. So the first question that I'm going to ask is, are you able to speak to best practices for managing ADHD while treating anorexia, e.g. use of non-stimulants instead of stimulants, and whether when it might be appropriate to reintroduce stimulants?
Beautiful question. It is, I will say, case by case for a lot of us, but in general, most psychiatrists will advise that if someone needs to weight restore when they're in anorexia nervosa, we're going to ask them to hold the stimulant. These things like Ritalin and Adderall can actually suppress the appetite, make it much harder for them to get through a meal because they're just not having those hunger cues. So holding it, monitoring the symptoms. If they are really struggling with focus and attention, we can introduce a non-stimulant. There are some pretty good ones, like I mentioned, Intuitive. These are effective, and I find that the clients like them. When you drill down to it, the clients on amphetamines like Adderall also describe a crash. They feel this effect, the stimulant, but then when it wears off, they don't they don't feel so good. They feel a bit tired. So there's not there's some benefits when someone has ADHD and they're in recovery. We would reintroduce it. I would say once they're closer to an ideal body weight, closer to over 85%, and that the dietitian can also work hand in hand to say, now they're able to eat their food on their own and maintain a weight that is towards recovery. Then we'd reintroduce the stimulant if needed.
Okay, thank you. The doses that you mentioned for the different medications, were they for adults or do they work with adolescents as well?
It's a good question. So I mentioned some doses for olanzapine, for example, which we use for those ruminating thoughts in anorexia off label. We do use those in adolescents. Again, they're not approved for that use. These are off label. So it's important for families to understand that there are side effects, and kids are always more susceptible to side effects. The dosing, we maintain low doses for adults and adolescents. So that I mentioned 2.5 milligrams. I might try even half of that for an adolescent, and we try to keep it as small as possible. But there are a couple of SSRIs that I mentioned, the antidepressants that are approved for adolescents. So we would start with those, for example, if they needed that, like the Zoloft or Prozac.
Okay, thank you. Is there a general timeline once individuals are food recovered before the insulin activity reaches levels that they were before the onset of the disorder?
Beautiful question. It can take over a year for the brain to fully return to its natural state of pre-eating disorders. So those studies that I showed, not just, it's a great question. I love that someone learned about the insula in the picture of the brain that was malnourished and lost brain volume. It could take about a year into recovery, once weight restored, and then eating over time for that brain to fully restore. So give that loved one grace and support. Recovery, once they're in recovery, that does not mean we pull off therapy and they get to go back to life and pretend like they didn't have an eating disorder. That year after is also critical to help maintain recovery. And that's when the brain will really restore.
Okay, I'm going to try for two more questions. How long is it safe to use melatonin for?
I mentioned that, it shouldn't be used daily for months. There's no set number that you can use it. I would say after 1 to 2 months, you really want to be pulling it back so that it doesn't disrupt our own natural production. But another way to do it is to alternate. Don't use it every night. Using it a couple times a week, every week, ongoing, not a problem.
Okay. Last question. I'm sorry, because I know there were a few that we didn't get to. Can you speak to weaning off olanzapine after someone is fully weight restored? How long should people leave? When do you start decreasing the doses? How does the weaning off work? Which I know is not a minute-long answer, but try your best.
Olanzapine and these medications like this are helpful in managing the eating disorder thoughts. And once someone is weight restored, we do, I would say once they're through, if they're in the higher levels of care, PHP or IOP, I wait and coach them, wait until you're in your outpatient, you're back at your life, you can challenge your eating disorder thoughts on your own, then we'll trial coming off of it. It is one good medication that actually works pretty quickly within 4 or 5 days, and you can stop it without necessarily having to wean down.
Okay, perfect. So thank you so much. This was really an amazing webinar. You guys were actually an amazing audience. These were such incredibly intelligent questions, and so relevant for so many people. So I just want to say thank you not only to Dr. Perlman, but to the audience as well. And I just want to kind of make a little pitch for F.E.A.S.T. 30 seconds. All of our funding comes from within our own community. And the only way that we can continue to keep our services like this webinar free is through the generosity of our community. So if you have the means, and if you have a minute, can you go to our website and give just a small donation? It would really, really help us. So thank you very much. And I just want to talk about the next month's webinar. It's going to be really interesting. It's called Eating Disorders Affect Us All. It's Stephanie Covington's personal story. I actually heard her speak at a conference about 10 years ago. She's fascinating. So I encourage you to join us then. Again, thank you so much, everyone, for joining us. Thank you again to Dr. Perlman, and I hope to see you all next month. Bye.